Hey, everybody, it's Dr. Eric Balcavage. We're back for another edition of Thyroid Shorts. This is episode 2. And in this episode, we're doing a follow up to the first episode where we talked about what makes up a comprehensive thyroid panel and what those lab markers mean. Today, we're talking about the timing of the blood draw in relation to the medication you're taking. So, keep in mind that whoever is ordering your lab work, they should tell you when to take your thyroid medication, and you should follow their advice. Here's some of the rules that I kind of work with my clients. One is, in general, I typically want a morning fasted blood draw. And usually, especially if the person's on T4 medication only, I just in general say don't take your thyroid medication before the blood draw. I'll explain why that is in a little bit. But let's talk men. First of all, we'll talk men versus women. Men doesn't really matter what time of the month you take it. You're not having a menstrual cycle. But if you're a cycling female, to me, the best time to draw your thyroid panel is either the first or last 10 days of your menstrual cycle. I prefer the last 10 days because some women bleed heavy. They can have anemia issues or develop some anemia issues if they have a heavy bleed. So I really prefer the second half of the cycle, the second 10 days of their menstrual cycle for optimal collection. In general, the rule for almost everybody is don't take any medications or supplements the morning before your blood draw, and preferably, especially when it comes to vitamins and supplements, I typically recommend that they don't take any supplements for 3 days leading up to the blood draw because we want to get them in their most natural state. Regarding medications, I don't prescribe medications. So if you're taking medication, I typically just recommend just don't take any medications the morning before the blood draw if possible. If you are going to take something or you did take something the morning before the blood draw, you should let the clinician know what it is that you took so that they can interpret the labs appropriately. So in general, I typically say don't take anything the morning before the blood draw. We'll talk about how that changes with potentially T3 here in a few minutes. There is a circadian rhythm to your thyroid labs. And so typically I like to have patients get their thyroid panel drawn before 9 a.m. if possible. If you're taking a T4 only medication, it really doesn't make that big of a difference on your thyroid labs if you did take your T4 medication before the blood draw. In general, I think it's best to keep it consistent. If you usually don't take your thyroid medication before the blood draw, keep that fairly consistent. If you usually take your T4 medication before, probably take it before. But in general, I just usually tell my clients, listen, let's not take it before the blood draw. Okay. So if you're on T4 medication and you're a male, just don't take your T4 medication before the blood draw for me, and try and get it done before 9 o'clock in the morning. If you are a non-cycling female, don't take your T4 medication before the blood draw and get your labs done before 9 a.m. If you're a cycling female, my best recommendation, if you can get it done, is to do it in the last 10 days of your menstrual cycle. My opinion. And again, B vitamins, definitely, and supplements, try not to take them for 3 days prior to the blood collection. Other things to consider. If you're taking T3 or a T4 T3 combination, then whether you take your thyroid medication, especially that T3 before the blood draw, depends on what you're trying to determine. If I'm working with somebody who's on T3 medication and still doesn't feel well with T4 and or T3 medication, I don't want them maybe off initially taking their T3 medication before they collect their blood. The reason for that is most of the T3 that's in circulation is not produced by your thyroid gland, but is produced by the peripheral tissues, bringing T4 in and converting that T4 to T3. And I want to see how well someone is converting T4 to T3, because if they're not converting T4 to T3, they could still have hypothyroid signs and symptoms despite taking T3 medication. So I don't want to see what they've manipulated with T3 medication. I want to see what they're able to do without. And because the half-life of T3 is somewhere between 12 and 24 hours, if we just have them not take their T3 medication in the 24 hours prior to the blood draw, or at least 12 hours prior to the blood draw, we're probably going to see a better indication of how well they convert T4 to T3 and less that T3 manipulation of the blood with their medication. Now, if we think somebody is on an appropriate dose of T3 and we want to see how high that T3 medication rises, makes their total T3 rise or their free T3 rise, then we would want them to take their T3 medication. In this case, they may take the T4 medication as well before the blood draw. But the timing becomes important. The max absorption of T3 is somewhere in about 4 to 6 hours. So in my opinion, the best time to test to see how high that T3 medication is driving up their total T3 and free T3 is about somewhere between 4 and 6 hours after they took the T3 medication. If they're taking a slow release T3, then they might want to time that collection somewhere around 9 hours after they took the slow release T3, because the max blood level is usually somewhere around 9 hours after they took the medication. So it really depends on what your prescribing doc is trying to determine or what your functional practitioner is trying to determine. There are some people that are just trying to manipulate T4 and T3 in the blood. And so let's say it this way. Many physicians are trying to just manipulate TSH with T4. So they don't really care. They don't care if you take the medication before or after, because the half-life of T4 is about 7 days. So they'll just tell you, get your labs done. A lot of times they don't even care about what time of the day it's done. If somebody is trying to optimize T3, they see that you on T4 only, you don't feel well on T4 only. They may look at T4 and T3, see that there's normal T4, lower T3, and therefore they may say you don't have enough T3 in circulation to get to the tissues. That's why you have hypothyroid signs and symptoms. So they're giving you T3 to try and drive up the blood levels of T3 and free T3, because they believe that if you flood the system with T3 and there's more available in the bloodstream, it correlates with optimal thyroid physiology inside the cells and tissues. And it doesn't, unfortunately. And I've talked about this multiple times on the podcast, is that we have two states from a thyroid regulating state. There's one called thyroid homeostasis, which means there's low stress on the cells and tissues, and the cells and tissues want a higher rate of metabolism. So they're rapidly converting T4 to T3 based on need. They're in a low stress state. If this was going on for you, you'd probably feel fine on T4 only. But most of the people that come to see me, at least, and maybe a lot of other people, they're not in a low stress homeostatic state. They're in a stressed inflammatory state. And because of that, their body is adaptively decreasing the conversion of T4 to T3. There's reduced T3 in the cells, and that's causing some of their hypothyroid signs and symptoms. Some people believe that reduced conversion of T4 to T3 is broken physiology, and the only way to optimize thyroid physiology is to provide the T3 that the body is not making. my philosophy is different. I don't think it's broken physiology. I think it's adaptive physiology. I think the literature points that out. And so it's in general, the T3 medication may make you feel a little, but it's not actually restoring thyroid physiology to a homeostatic state in the cells and tissues, which is why many people who go on T3 medications, either as Armor and Thyroid or in conjunction with their T4 medication or T3 only, feel better initially and then kind of plateau and then need a stronger dose. And then they plateau and then need a stronger dose. And they're kind of trying to chase the right amount of T3 to put into the system. So to summarize all this, ask your clinician what they want to measure when they're ordering your blood draw and kind of follow their advice. But if you're ordering your blood work or you're working with a functional medicine practitioner who's trying to find out why you don't do a great job of converting that T4 to T3, ask them what they are trying to accomplish with the blood panel that they just ordered. Many times, as I said, I'm trying to figure out how well they're converting T4 to T3 in the cells and tissues. And that T4 could be either what the thyroid gland is still able to make or from the medication or the combination of that T4 that's in the bloodstream that's available. How well are they taking that T4, converting it to T3? If you take your T3 before we collect the blood, we're not necessarily seeing how well you convert T4 to T3. We're just seeing how much T3 is in the bloodstream, partly from T4 to T3 conversion, and the rest of that is from what you just loaded into the system with your medication. And this is really important. Sometimes I've seen labs where people are on Armor and they're not taking their medication before the blood draw. And so because they didn't, their T4 is normal, but their T3 levels might be low because they have this cell stress, reduced conversion going on. The T3 and free T3 are low, and the person who's prescribing doesn't realize that they didn't take their medication before their collection, sees their T3 and free T3 low, and starts ratcheting up their dose of Armor and Thyroid or their T3 dose. And this can cause somebody to become over medicated with T3 because nobody's monitoring how high it rises. I recently worked with a client. We ran their thyroid panel before the T3, and then they took their T3 and we ran another thyroid panel. And the total T3 and free T3 levels were dramatically different. What's interesting is this person still felt hypothyroid, even though they were taking, I think, 25 micrograms of T3. So they thought maybe they needed to increase it even more. But when we looked at the labs drawn before they took the T3, you could see there was reduced T4 to T3 conversion, and it was hidden when they took the T3 medication. T3 levels rose, free T3 levels rose. And so they're on their post-medication labs, their total T3 is lab high. It's above the lab reference range. The free T3 was lab high. But why are they hypothyroid? Do they need more T3? No, the reason they have hypothyroid signs and symptoms is because there is reduced peripheral conversion of T4 to T3 inside cells and tissues. And the cells and tissues, they bring in T3. They can help top off how much T inside the cells and able to bind to receptors by converting T4 to T3 inside the cells. And that T4 that's converted to T3 inside the cells by something called deiodinase 2, that T3 can stay in the cell and bind to receptors for a much longer period of time, hours, maybe up to 8 hours in some tissues, versus the T3 that's just brought in from the bloodstream may only stay in hitting receptors for 30 minutes or less. So it does make a difference how well you're converting T4 to T3 inside the cells and tissues. And that may be the big factor why you don't feel well, not because there isn't enough thyroid hormone available by your thyroid gland or your medication, but because the cells are actively deactivating the T4 and the T3 that's being brought in because there's a cell stress response. And keep in mind, not all tissues, all cells and tissues regulate thyroid hormone the same. Some have a heavier dependence on deiodinase 2 convert T4 to T3 inside the cell, and some cells and tissues heavily dependent on the T3 in circulation, and they don't much T4 to T3 conversion via deiodinase 2 inside the cell. The liver is a prime example of that, highly dependent on the T3 in the bloodstream. So if somebody takes T3, that can drop their lipids pretty quickly because the liver then can process it has more T3 to run the metabolism, to pull the cholesterol out of the bloodstream. But other tissues may still struggle, even though there's plenty of T3 in the bloodstream with the T3 medication. So I hope this helps. Obviously, the advice of your prescribing doc and the doc who ordered the blood work, right? That becomes important. And what the timing of your meds to your labs really depends on doctors trying to determine what your functional medicine practitioner is trying to determine, and maybe what you're trying to determine. Okay. This helps. If you have any questions, put them below wherever you watch the video. If you have personal questions that you want answered, you can always go to my website, regenacenter.com, and schedule a complimentary discovery call. I also have a book out called The Thyroid Debacle that I wrote with my good friend, Dr. Kelly Orman, that gets more in depth on my philosophy about thyroid physiology and what we're doing really well for people, both in the allopathic model and to some functional model. So hopefully this helps. Share it with your friends and family. And chance, it would be great if you would give me a rating where you watch or listen to your podcasts. All right. Thank you.